Hi, all. This is Eric Christensen from MedEd101.com. Just going to touch on a big problem that I see out there, medication reconciliation. My background's home care, long-term care, MTM, assisted living, and I see a lot of people transition from hospital to assisted living to their home, whatever the case may be, and it's a huge problem where medications get basically screwed up, get messed up, things fall through the cracks, and I'm gonna highlight a few points here in this brief presentation about that stuff. So, why are there so many changes? And if you think about it, any new or worsening condition, so any new disease state, any new symptoms that a patient's experiencing, it's going to lead to them visiting a healthcare provider. Whether that be a clinic, whether that be a hospital, can certainly vary. But new changes that a patient reports is likely going to lead to, or oftentimes leads to, new medications. So that's one main cause for medication changes. I think a hospital formulary situations where we change those medications sometimes, for cost savings purposes or whatever. But I remember a specific case where I had a gentleman on 2 statins after he got discharged from the hospital. Didn't recognize, didn't understand, wasn't educated, whatever the case was. He ended up, on 2 different statins, and he was confused because on the discharge summary, that alternate statin was listed on there, the statin that was supposed to be discontinued, as well as his home statin, and he ended up taking both. Insurance coverage, maybe not so much in the hospital setting, but outpatient certainly. We see it all the time where you need prior authorization. This medication's not covered now. You see all sorts of changes for that reason. So that can be, trip people up and be unrecognized when it comes to moving along the lines and, maybe going to a hospital where their medication list maybe doesn't match up now. OTCs and herbals, this is something patients don't think about, they forget about all the time. I think of a classic example, NSAIDs available over the counter, causing CHF exacerbation, maybe a GI bleed, somebody on Coumadin or aspirin and Plavix. Just a really common situation where over the counters maybe aren't told to us as healthcare professionals, or they simply get missed. So here's a quick case, just kind of to sum up an example here of how you simply paying attention can make a difference. This was a scenario I recall where a patient was hospitalized for a GI bleed. So when I think about a situation like that, we've got to recognize what they were in the hospital for. And then thinking about that, I want you to apply that and look at, do those medication changes make sense for what they were hospitalized for? Now, your setting's going to depend how much information you're aware of, you're able to get access to. I realize that certainly can vary depending upon the site that you're practicing in. But still, we can do something. We may know something, and information is important. If we understand that a patient is hospitalized for a GI bleed, omeprazole being started, that totally makes sense. Plavix being discontinued, probably a likely scenario. That makes a lot of sense. But here this patient was started on Prozac 40 milligrams daily. Now, starting a antidepressant at a moderate to high dose on a 3-day hospital stay, does that really make a lot of sense? So that's a situation where it's like, it's a no-brainer where we got to ask some questions and identify what the heck is going on here. So hopefully that helps give you guys a little sense on MedRec issues. And as always, be sure to check out the blog, meded101.com. Feedback's always welcome. Your support is greatly appreciated. Plenty of things available if interested regarding board certification, BCPS, CGP, AmCare exam. So you feel free to check those out and message me if any questions. Thanks. Have a great day.